Cool.
Yeah. Yeah, I got the one little square up here in the corner, and usually it's my face that's on there. So, okay, we're recording now. Okay, we'll just jump right into it. This this week we're talking about immune mediated disorders. I'm sure like the buzzword that has really come down lately is autoimmune disease. They really seem to have gotten more prominent in recent years. I remember when I was a kid, we didn't there was no such thing as autoimmune disease, but there were probably some things out there that we didn't know what they were. That probably fell into this category, but we're getting more knowledgeable about it in recent years. But to put it simply, it's just a matter of your immune system attacking your own body. In a nutshell, that's what it's all about. Remember this guy, my angry bug. You see him, you might see that stuff on the test.
Okay.
I like that guy.
Yeah. Can I ask a quick question about that guy? Is that
Sure.
the critter that is from that weird athlete's foot commercial?
What's that?
Is this the thing that's from the athlete's foot commercial?
Probably.
Okay.
I just stole him off the internet. I really have no idea, but I thought, oh, wow, he looks cool. I'm going to take him.
Okay.
He does look like athlete's foot, doesn't he?
Yeah.
I can make some comments about ex relationships, but I'm going to leave that alone.
Sorry, that's funny because I could totally relate to that too. Oh, that's funny.
Okay, well, start again. Oh, actually, before we talk about autoimmune disease, we're going to talk about allergic reactions. Allergic reactions are they're really not similar, but allergic reactions are just when your body overreacts to an allergen. Anybody out there with hay fever?
Yep.
Yeah, you know what allergic disorders are. The immune system launches a response and they really overreact. It's your allergic system being dramatic, is what basically it is. But it overreacts to allergens that are really not that harmful to you. For example, inhalants. Now, this is where we get hay fever and all those wonderful things when the dandelions are blooming and all. That is an example of an inhalant allergic disorder. They can occur at any age, and I'm going to I'll go into a little more detail here in a minute, but you can not be allergic to something for a long time and then poof, you develop an allergic disorder. Some of the examples are food and drugs. We all know about drug reactions. People have had, penicillin is a very common allergic reaction. Well, one thing I'm going to point out here that you're going to run into in your nursing career is you will be asking people, are you allergic to any drugs? And they're going to say, yeah, I'm allergic to penicillin. And it's always important that you ask them, so, okay, what kind of reaction do you have? Because if they get hives or short of breath or anything of that nature, that's a clear indication that they are allergic to that drug. But quite often people will say, well, it makes me nauseated. Well, nausea is not an allergic reaction to a drug. That's a side effect. So you all understand the difference between that? Because our patients don't understand the difference. So I'll ask them, I say, okay, what was your allergic reaction to penicillin? It made me nauseated. Well, that's not an allergic reaction. That's a side effect of the drug. So that's just something to kind of stick in your back memory there. If they develop hives or something, and that's usually the most common reaction people will have to like penicillin or antibiotics, is they'll get a rash. And that is a true allergic reaction. Another example of a food reaction is seafood. And you've had I'm sure you've run into people that are allergic to shellfish. Actually, it's the iodine in the shellfish that causes them to react. And that's important to know because that can be serious enough that can actually kill somebody. We're going to talk more about anaphylactic shock as we go along here, but people can have seafood or the iodine in seafood and actually have an anaphylactic reaction to it. And that's important for us to know because a lot of our contrast dyes will have an iodine derivative in it too. And so we can send somebody to the cat lab and have them do a contrast, and they can have an allergic reaction to that contrast. And that contrast can actually be life-threatening. So it's very, very important that we know if they are allergic to seafood. If they're allergic to seafood, we cannot use our contrast dyes. So that's why we have to know that information. Inhalants, as I just talked about, were dust, house dust, mites, hay fever. Anything you inhale through your nose or your mouth is going to be an inhalant. Contractants, those are the ones that are in contact. And of course, the most common one is latex. But we've all had, most of us have probably had some kind of reaction like that. Well, my mother used a certain type of detergent one day on my clothing, and I just started developing a rash. So we figured out it was the detergent. There was something in the detergent that I was allergic to. So that'd be a contact allergy. And of course, injectants would be a drug. That could be a drug. There again, it could be a penicillin reaction, but you're getting an injection rather than taking a pill. But the most common one is animal venom, or not animal venom, but insect venom like bee venom. Someone's allergic to bees. There again, that's usually an anaphylactic reaction and can be life-threatening. So they definitely have to be careful on that.
I have a question, Bryce.
Sure.
So if somebody, like for myself, I'm allergic to cats, right?
Yes.
So is that an inhaled issue or is that contact?
I
don't
believe
seek out petting cats, but if I'm even in the same room, it's not pretty. So I was just curious if it fell into which one of those.
I would say it could be both. The dander in cats, I mean, my wife is that way. If she walks into a room and inhales, she'll have an allergic reaction, sinuses swell up and all.
Yeah.
The contact allergies usually manifest as some type of rash.
Okay.
But you can pet a cat and have a reaction to that as well. So, I mean, it's the same allergen, just two different methods of getting into your body.
Okay. Thank you for clarifying.
Going back, you might want to pay attention to those 4 different methods of getting an allergy. So this is what I was saying before. You could not have an allergy to something. And usually your first reaction or your first exposure to something, you probably will not have an allergic reaction. For example, you may get stung by a bee when you're 12 years old. Okay, it hurts, but no big deal. And then in 5 years later, you get stung by a bee again and you have a full-on allergic reaction. The reason for that is your body has to be exposed to the allergen first in order to create a hyperreaction or an overreaction to the allergen. So you may have you may have gotten stung by a bee when you were young, but didn't have any reaction to it and think you're okay. But then the second time you do have a reaction, and this process is called sensitization. So the allergen gets into the body and all that stuff we talked about with your B cells and your T cells, and your B cells form the antibodies to it and everything. And it's all ready to attack it the next time it comes into your body. And then the second time you're exposed to it, or maybe the third or fourth time you're exposed to it, then your body launches the allergic response. And that's when you have an all-out allergic response to the allergen. There's 4 kinds we're going to talk about. The first 3, type 1, 2, and 3, are immediate reactions. These happen within minutes or even an hour or 2. And then the type 4 is a delayed reaction. That's, and we'll talk about that. Sensitization, you want to remember that. The immediate hypersensitive responses are, like I said, the type 1, 2, and 3. And basically, these are just different ways of classifying which immunoglobulins are reacting to your disorder. The most serious one is the type 1, which is the atopic or anaphylactic shock. or anaphylactic reaction. It's not shock, it can lead to shock, which is what it's in. And I'll explain to you how that works. But immunoglobulins are antibodies, and there's about, I think, 4 or 5 different types out there. So depending on which immunoglobulin reacts, it determines whether it's a type 1, 2, or 3. Just remember, type 1 is an anaphylactic, and that can be the most severe. I think it talks about the details about type 1. If not, then I will fill you in on that. But one of the things that a body can do during an allergic response is it releases the cytokines. But what these do to your blood vessels is they make your blood vessels dilate. And okay, I'm off track. That's if you have anaphylactic shock. The other problem with anaphylaxis, there's a couple things wrong with anaphylaxis. I'm going to wait till we get to that slide. But you can go into shock from anaphylaxis, and you can also have bronchial restriction from anaphylaxis. There's several different things that can go on with anaphylactic shock. So I want to wait till I get to that slide so I can cover that in more detail. Anyway, type 2 cytotoxic is mediated by different immunoglobulins as well. And then there's a type 3. Oh, okay. I don't have an angry bug on that one. But anyway, remember, just type 1, 2, and 3 are immediate responses. 1 and 2 are within minutes. Type 3 can be within hours. But type 4,
Bryce, I had a question.
yes.
With regards to type 1, 2, and 3 being immediate reactions, do we need to know like which immunoglobulin goes with each type of reaction?
No.
Okay. Next question on a more personal note, with the coronavirus coming out and the vaccine, coronavirus vaccine coming out, I've read a lot about people having anaphylactic reactions. So my question is this like, Pierce County, for instance, just announced all these drive-through locations that you can set up appointments for to go through. Is that something you really want to do if there's like a known potential for anaphylactic shock? I mean, if you're sitting in your car and you're halfway home driving behind the wheel of your car and you start having an anaphylactic shock, I mean,
that's a good point.
Really prepared? You know what I mean? Just
they are probably prepared at the site. If this becomes more common of a problem, they will probably ask you to pull over and wait a few minutes. If you're going to get anaphylaxis, it's going to be immediate.
Yeah.
So even if they don't tell you to, you might want to just pull over and park for a while and, spend 5 or 10 minutes talking on your cell phone or something. If it doesn't happen, I say within about 5 or 10 minutes, it's not going to happen. Anaphylaxis happens like right away. The most familiar one I'm familiar with is a bee sting. Bee sting. The most dangerous part about an anaphylactic shock or anaphylaxis is the fact that it causes your bronchial tubes to constrict.
Mm-hmm.
And your body's hyperreaction, it causes the tissue in your bronchial tube to swell, and your throat can swell shut and you can't breathe. And so asphyxiation, of course, is the most common detriment to that particular reaction. I'm sure we've all seen it before, on TV, if not in real life, where someone either eats shrimp or they get stung by a bee and then they can't breathe, and you got to get the EpiPen into them and give them epinephrine immediately to get those bronchial tubes to relax again so they can breathe. I'm pretty sure that at the site they will probably have epinephrine. So if you pull over after you get your injection and suddenly you're having difficulty breathing, I would get out of the car, mask or not, and go back over and say, I can't breathe. Right. And then they should be able to give you an EpiPen shot. Or if any of you are allergic to bees and have EpiPens already, it might be a good idea to take it with you. But they should be prepared for that situation at the site. But that's new to me. I didn't know that was going on. I know some people, I read an article that one person had died from the shot.
Yeah, I had
But I
read,
didn't read the article, so I don't know how he died from it.
yeah, there were a lot of the articles I read were that people were having anaphylactic shock and, they obviously were resuscitated and everything was fine, but I'm just,
Yeah.
picturing this drive-through McDonald's type thing going, doesn't seem safe, and I mean, if I was going to get an immunization, it'd be one thing going into a clinic where there's, doctors
Yeah.
on staff and emergency equipment, but I'm picturing a drive-through and pulling over and, somebody who just handed me fries is trying to revive me with an EpiPen. I don't necessarily, I feel like I'd feel that safe.
Well, all those places, they should have medical personnel on hand, with like complete ambulance and like that's a common, I mean, I can't think of an ambulance in the world that does not have epinephrine on board because that's cardiac arrest and epinephrine. I mean, they all have to have it. It's probably the most common drug you'll find on an ambulance. So
Don't use Falk Ambulance Company because my oldest son is an EMT for them, and they have been as EMTs they have been complaining because their rig does not have EpiPens.
do they have the bottle of epinephrine?
No, they have nothing. My son's pre-med and he's applying for med schools right now, and he's throwing a fit with management and the union to try to get EpiPens on board.
If you're a paramedic, you are authorized to use epinephrine. So
Yeah,
I don't understand what's going on there. Yeah.
Yeah, he is an EMT, first responder, not a paramedic. So I don't know if there's a distinction there, but anyways, yeah.
EMT though, that's different. It's an EMT ambulance. They don't have that.
Yeah. Which is sad, but yeah.
I'm gonna move on here.
Okay. Sorry.
I don't know if we're going into more detail. I know so on this slide that we get into the cytotoxic type 2 and type 3, but if there's not more detail on anaphylaxis on these next couple of slides, I will certainly tell you about it. These next two, cytotoxic and immune complex, are a little bit different. Type 2 cytotoxic is present in that's the kind of reaction you have in transfusion reactions in hemolytic anemia. So that's not going to be a very common one that you're going to see, unless of course you have a patient that does have a blood transfer reaction. But there again, the body is seeing the blood as a foreign object and launching an immune response against the blood that you receive. It can be fatal. So that is why we go through so many different tests when we're giving somebody blood and all the different steps we go through. And as you will see in the future, giving blood to a patient in a nursing environment is quite an involved process, and for good reason. Type 3 immune is related to the autoimmune diseases. The type 3 occurs in the lupus, rheumatoid arthritis, glomerulonephritis. These are just reactions where the body is seeing its own tissue as foreign tissue and attacking it. And we'll be talking more about those as we go along here. Okay, here's anaphylaxis. Because I say that's type 1. That's the most serious one. That's the one we got to pay attention to. Massive release of histamines cause vasodilation and increases capillary permeability. What's happening there is, for example, you go to the store, your sinuses are running, you buy an antihistamine. Histamine is released by the body in reaction to allergens. So if you buy an antihistamine, like Sudafed or any of those kind of things, basically it's telling your body, quit producing the histamines, you're producing too many. But in the case of anaphylaxis, it releases so many histamines, and histamines will not only make your sinuses run, but they make your blood vessels dilate. And if your blood vessels dilate too much, your blood pressure drops into the toilet and you go into shock. And it can literally kill you. So anaphylactic shock is one way that anaphylaxis can kill you. The other way is through the swelling. And in that case is when the bronchial tissue, you can see down here, bronchioconstriction, it will cause the swelling of the tissue which can literally cause your windpipe to swell shut. So there's two things there with anaphylaxis that are actually life-threatening. I don't think oh yeah, okay, we'll be talking about that on the test, but I would definitely pay attention to anaphylactic shock and anaphylactic bronchoconstriction. It's very important. The delayed type 4 is the one that takes place over a long time. So that is, and it's in the name, delayed hypersensitivity response. And that's basically where the T cells are producing too many cytokines as part of a allergic response. I have an article on cytokines that I came across in my email or something. I think I'm going to try and find it, and I'll put it on. I'll put it on this website. The cytokines are really fascinating. They're like the little messenger that run around in your immune system, and they're pretty fascinating. Oh, yes, you got to remember that one too, right? Any questions on those? Going once, going twice.
I don't think so. I feel like those are pretty straightforward.
And remember, type 4 is a delayed response. Nurses assessing the patient, which are the following symptoms that the client with anaphylaxis may be experiencing?
Wheezing.
Wheezing, beautiful. Now these others here, dermatitis, I don't know where delirium came from, sinusitis, those are reactions, but they're not necessarily anaphylactic reactions. The anaphylactic reactions is going to be from the histamines, well, not the histamine on the dilation, but the angioneurotic edema, where it's causing the tissues to swell. Okay, now we're getting into some allergic disorders. Several different mechanisms. Let's go back. Okay. These are some of the ways that we use to counter the allergic responses. I know the one that caught my attention the most down here was corticosteroids. But these are ways that the body attempts to counter your body's allergic response. And these here take place in the body, the ECF, which you don't hear a whole lot about that. And the chemotaxis is your body's own reaction to trying to suppress the allergic reaction. But the epinephrine, although your body is producing epinephrine and corticosteroids to counter the effects of the allergic reaction, these are also drugs that we can give to you to help boost your body's reaction to the allergic response. There again, the epinephrine, in the case of the person having an anaphylactic reaction, we would give them epinephrine because it interferes with those chemicals, those vasoactive chemicals that are causing your tissues to swell and causing your blood vessels to dilate. Epinephrine is our first #1 choice in the case of an anaphylactic reaction, and that is what is in an EpiPen. I think Eileen is going to, did they give you instructions on how to administer an EpiPen?
Not yet.
Not yet, we will. I know it's going to be one of our classes. The other one is corticosteroids. Corticosteroids are the steroid shots you hear people talk about getting in their knees and in their hips and in their joints. Corticosteroids include the shots that you get in your joints. It includes solumedrol. We use solumedrol a lot. It's an injected form of corticosteroid. We use that a lot with asthma patients, children that have asthma. And you can also take it orally in the form of prednisone. Prednisone is a corticosteroid. This blocks the prostaglandins and the leukotrienes, which are causing the inflammatory process. Unfortunately, corticosteroids have a lot of nasty side effects to them, but they are the most effective anti-inflammatory medication that we have. So we're kind of stuck with it now until we find something better. It's one of those, which is the lesser of two evils. But when it comes to anti-inflammatories, you can't beat corticosteroids. Normally what will happen with somebody who has an inflammatory response is we'll start with Sudafed or Benadryl. Then we'll move on to Solumedrol. And then if the Solumedrol doesn't work, then we move on to epinephrine. Now that's in a normal inflammatory response. If it's anaphylaxis, we just go straight to epinephrine. Any questions on that?
Can you say that order one more time?
Do what?
Can you say that order one more time? For if it's not anaphylactic, you go in order, you use what? I'm sorry.
If it's not an anaphylactic reaction, often we will start with Benadryl or Sudafed. Now these are antihistamines. So that's why we use those. They are similar to the epinephrine in the sense that they block the release of those chemicals that are causing inflammation. I'll give you an example. I went to Mexico one time, and the person I went with was a flight nurse, and so she had this, first aid bag like this big when we checked in. We went to a restaurant, and I had this breaded fish, and I've had it a couple times since that event. And there's something in the breading that my body doesn't like. But anyway, about 2 o'clock in the morning, I'm breaking out with this rash all over my back. The first thing I did was I took some Sudafed and some Benadryl. Now, when kids have rashes or reactions or anything like that, Benadryl always is the first go-to, right? I mean,
Yeah.
all the mothers out there, oh, he's getting a rash, give him some Benadryl. Or if someone gets poison ivy, you can put Benadryl cream on the rash area if it's a contact dermatitis. So that's always kind of the first line of defense. If it's a major reaction like anaphylaxis, then we go to epinephrine. Epinephrine is just like the Benadryl and Sudafed, only much more powerful.
Okay.
And then for long time inflammatory problems that, the Sudafed and Benadryl and the epinephrine are not going to take care of, then corticosteroids are a long-term anti.
For a while.
Somebody's got their microphone on. Thank you. So corticosteroids are like a long-term, whereas epinephrine is more of an emergency situation.
Yeah.
But that's good to just put in the back of your mind too. If you're ever out with somebody and they're having seafood and their throat feels scratchy, you might want to start with a Benadryl, see if that, or if they start developing a rash. Now, the Sudafed and the Benadryl took care of my rash and it went away, so I didn't have any problem. But if I'd have started having trouble breathing, then we would have gone to a clinic and they probably would have given me epinephrine at that point. But as far as the long-term inflammatory response, like athletic injuries, rheumatoid arthritis, osteoarthritis, and we use corticosteroids for those because those are long-acting. You'll probably get a lot of this in your pharmacology.
I have a question about the epi. How many times can you give it if in an anaphylactic? Do you know what I mean? Like, do you give it every so many minutes or?
Yes. Yeah, there is a curve to it.
Okay.
Usually the first dose will take care of it, and then we use a corticosteroid for long term. So in other words, if somebody is having an anaphylactic reaction, we'll give them epi immediately, which should immediately start relaxing the bronchial tubes. And then we'll start them on Solumedrol, which is a corticosteroid, which should reduce the inflammation for a long time. So you have a short acting and then you have a long acting. It's almost like insulin, short acting insulin, long acting insulin. If while we are giving them, if we give them the epinephrine and give them the solumedrol, but then they start to have another exacerbation of that, we can give them another dose of epi, and hopefully over time the solumedrol will take over. This reaction will kind of come and then it will go. We're trying to just kind of get them over the hump. Very rarely will an anaphylactic type reaction go on for a long time. It just kind of flashes.
Okay, thank you.
You'll be dealing a lot with that in the ER or in the hospital, maybe not so much related to anaphylaxis, but with asthma. Because with asthma, it's kind of a reaction that's similar, where you get a lot of laryngeal edema. You know, usually young kids with asthma, and they just can't breathe. So it's the same. We use the same process. You know, if it's mild, we just give them some Benadryl. If it's severe, we give them some epinephrine, but then we give them corticosteroids or solumedrol over a longer period of time. We may even send them home with a prescription for prednisone, to take prednisone over the next week or so. That was just a nice little chart about all the kind of different symptoms you can have in allergic disorder. And here again, the different scales of seriousness. The less severe stuff is sneezing, rash, itching, the stuff you get with hay fever. With food allergens, you can get some cramping, diarrhea. We usually probably think it was food poisoning. It might have been allergic reaction. There again, with seafood, a person might feel a scratchiness in the throat. That's not a good sign, but if it goes away, you're okay. But if it begins to affect them to the point where they're having difficulty breathing, then you have to get them to epinephrine. Here are some of the different kind of tests that we use for allergic disorders. You might hear RASP thrown around. That's a blood test where they test for different allergens. Probably the one we're most familiar with is the good old-fashioned scratch test. That's where they take an area, usually of your back, and they take the different allergens and they poke them into your skin and they see which ones react. Anybody ever had to go through that?
Oh, yeah.
Yep.
It's pretty common test. If you're having allergic type reactions as a kid and they can't figure out what's causing it, they'll do that. Complications. You can develop polyps. I've heard of that happening. And then secondary infections, asthma. I'd have to go back and review my information on asthma, but I'm not sure what sensitivities cause people to develop asthma. That's in a different section anyway, so we won't worry about it now. Okay, this is what I was talking about earlier. We might start with drug therapy using diphenhydramine or Benadryl and pseudoepinephrine, brand name Sudafed. There is, I don't know if any of you have ever had to go through this process at all or not, but there is a desensitization process where you go into the allergist and they give you an extremely diluted form of the allergen over a long period of time. And that should cause your body's immune response to kind of calm down so that you don't have a hyperreaction to that allergen. Yeah, that's what they commonly call allergy shots. You probably heard of them called that. Mm-hmm. I kind of funny because if you think about it, that's a form of homeopathic medication. But you didn't hear me say that. Sublingual swallow immunotherapy. I've never heard of that, but it was in the book. Nursing management. If somebody is swelling, now this is true of a lot of different situations. For example, if someone is having any kind of reaction where their body parts begin to swell, you want to make sure you get their rings off. Most ERs will have a ring cutter. I know a lot of people shouldn't be wearing rings at work, especially mechanics. You probably see most mechanics don't wear rings because if they break their finger and it starts to swell up, that ring acts like a tourniquet. Very, very serious. So any hobby or career or anything where you're risking hurting your fingers, mountain biking, whatever, you shouldn't wear your ring. Take your ring off before you do that. Diagnostic skin testing, which we already talked about. You will be responsible when they prescribe an EpiPen to your patient who had a reaction to that bee sting. You're going to have to teach them how to use the EpiPen. It's really a no-brainer. Take the cap off, bang it against your leg. Serial doses. And of course, the obvious. Where'd my pointer go? There it is.
I was going to say something about the EpiPen. The people around them really need to know how to use it, because I have a severe allergy to bees and I don't have enough time to shoot myself if I get stung. So everyone around me has to know how to do it. I can grab it, maybe it's usually close, but I don't have it in me now to be able to shoot myself.
Now, have
So,
you taught your family?
Yeah, even my 8-year-old knows how to do it.
Good.
Yeah. So I think everyone around the person also needs to know how to use it.
I think if somebody was going down, if you could just reach in and pull the EpiPen out, there should be somebody in the area that would look at the EpiPen and go, oh, that's what they need.
Well, usually someone with allergies severe already knows and has it on them, and whoever they're with usually has an idea of where it is. Like whenever I go somewhere, I say, oh, like in school, Farron knows it's in my backpack. She knows exactly which pouch it's in, so she can just go grab it for me. So like wherever I am, someone knows where it is. You know what I mean?
Good.
Yeah.
Well, that certainly covers that point right there. Don't just teach the client, teach the family. Because you're absolutely right. I mean, you could go down and be unable to do it yourself. Nurse would evaluate that the patient understands what triggers allergic rhinitis by which of the following responses. Okay, rhinitis is going to be what type of allergic reaction? Going once.
Airborne pollen and molds.
Inhale it. You got it. What is rhino?
Nose.
Rhino is Latin for nose. Remember rhinoceros? So if it's allergic rhinitis, that means the nose, they're all that crap coming out of your nose. Very professional way to put it in. Okay, that was allergic responses. Allergic responses are an overreaction to a pathogen. When we get to autoimmune disorders, it's kind of similar in the sense that your body is overreacting to something, but it's not an allergen that it's reacting to. It's reacting to something that's actually a part of your own body. I think this has been disproven over time, but I know when rheumatoid arthritis first came out, and this is a good example of what I'm talking about. They thought that those who developed a staph infection, they thought that the cartilage in the human body, the structure was similar enough to the Staphylococcus aureus bacteria that after the body went through and killed off the Staphylococcus aureus, which it should do, that it mistaked cartilage for the Staphylococcus aureus bacteria, and it began attacking the cartilage. As you'll see here in a minute, with rheumatoid arthritis, your body is basically attacking its own cartilage. But that is and I think they've since disproven, they're not sure that really that's how it works with rheumatoid arthritis, but that is an excellent example of how an autoimmune disorder works. It finds something in your body that is truly yours, but your immune system thinks it's not. And it's usually the killer cells, the natural killer cells, or the killer T cells. I have a hard time finding that pointer. I wish they made it bigger. There we go. Killer T cells. goes through and attacks your own natural cells. Now, remember when we were talking before about your body's natural cells are running around and they have this little ID card with histocompatibility marker, which we call the MHC1. Now, this is your cell's ID card saying, hey, I belong to this body. But for some reason, your body's immune system fails to recognize that as a part of the body and begins to attack it. And depending on which MHC1 it's going after will determine what type of dysfunction, autoimmune disorder you have. For example, multiple sclerosis is it attacks the myelin sheath on your nerves and eats the myelin sheath. Hemolytic anemia, it's attacking your blood cells. And so those are kind of examples of different types of tissue your body's immune system attacks. I think we pretty much covered that slide here. We'll talk in more detail. Hey, there's my angry bug. As far as causes go, that can be kind of iffy sometimes. Tissue injury theory, sometimes a body might get an infection. Now, this would be a classic example of what I was talking about, where you got an infection of the Staphylococcus aureus and your body fought it off, and then nothing put the brakes on them, and they just went on to attack other parts of your body that were indigenous to you. That would be an example of infection. Or if you have some type of trauma and the body counters by attempting to contain that trauma and kind of overreacts and goes overboard on it. There again, the key word here is theory. There is still a lot of mystery relating to what actually causes some of the infections. Some of them, it might have been a previous infection. Some of them, they're thinking there might be a genetic factor. One we do know about is the staphylococcal infection and rheumatic heart disease. They have made that connection. And that's very similar to what I was talking about with the rheumatoid arthritis. Sequestered antigen theory. Don't ask me what that is. Don't worry, I won't test you on it. But there is still a lot of mystery to what's causing some of these diseases to occur. Lupus, chronic fatigue syndrome, rheumatoid arthritis, we don't really yet have a handle on exactly how to diagnose those or how to counter them. Even though the diseases can be very different, lupus is very different than rheumatoid arthritis. However, lupus and chronic fatigue syndrome can be very similar to each other. But all of these diseases are an overreaction of the immune system. And whenever you get an infection, say the flu, and actually all of the symptoms of the flu are not from the flu bug itself. The symptoms are from your body's reaction to the virus. So the low-grade fever, they're trying to burn out the virus, the malaise, the fatigue, your body's redirecting energy toward fighting the infection, so you don't have the energy. Weight loss, you lose your appetite. All of these symptoms are your body's reaction to the infection. But unlike the flu, this is your body's reaction where it's attacking something in your own body. But all of the chronic fatigue or all the autoimmune diseases will usually start with the manifestation of these flu-like symptoms. Which, I mean, makes sense. It's your immune system, right? This is also important here. It's usually not a straight line. You don't get rheumatoid arthritis. It goes like this. All of these are your immune system overreacts, and then it gets it under control and it goes back to normal. Then it overreacts and goes back to, so you're going to go, it's going to be like a roller coaster. you're going to have exacerbations. For anybody who doesn't, may not be familiar with the term exacerbation, that's when the symptoms get worse. It's an exacerbation. And remission is when the symptoms go away. So you're going to have alternating periods of exacerbation, remission, exacerbation, remission. It's not going to be a straight line. Angry bug. There are some tests that kind of give us a clue of what might be going on. And as I talk about some of these others, you'll see that some of these diseases are simply a process of elimination. But the erythrocyte sedimentation rate, we'll talk more about that when we do labs. And then there's some other tests. Rheumatoid factor doesn't say you have or do not have rheumatoid arthritis. It just basically, if you have it, you may have more of an inclination to get it. So even that is not a concise test by any means. Different types of drug therapy. One to remember, if you have a transplant, now that's a case where the body's attacking one of your organs because it doesn't recognize it as being a part of its own natural system. And it isn't, and that's very true. So you get a liver transplant, or not a liver transplant, say you get a kidney transplant, we have to give you autosuppressive drugs to keep your immune system from attacking that kidney. And I'm sure you've probably heard of that in transplants before. If you transplant any kind of organ or body part from another person into your body, we have to give you immunosuppressant agents to keep your body from attacking that. Well, it's the same theory. The only difference is your body is attacking one of your own body parts, but we can still use the immunosuppressant drugs to kind of just cause your immune system to calm down, is a good way to put it. There again, there's some cytotoxic agent for a cytotoxic reaction. We can use that. And then again, there's the corticosteroids. This counters the inflammation process that goes along with the immune response. This would be especially true in the case of rheumatoid arthritis because you get a lot of the swelling in the joints. Nursing management. Family history is very important because certain autoimmune diseases run in the family. Vital signs, of course, on everybody. Look for areas of inflammation. That, especially on the case of rheumatoid arthritis, you'll see the swelling in the joints. Assess their energy, a level of energy. I'd also just assess them for flu-like symptoms. And then you're going to run labs on them. Whoops, wrong way. It's unknown what the triggering mechanism might be in some of those. There again, a lot of this is still a mystery. There are some symptoms that you have an autoimmune disorder. Some of these are characteristic. For example, the facial rash. This is a rash that kind of goes on your face and it kind of spreads like this. And it looks like a butterfly, and that's why we call it a butterfly rash. That is indicative of lupus. If anybody has lupus, they're likely to get that. Behavioral disturbances, that's just secondary to everything that's going on in your body. You can get some edema and some protein in blood in your urine. There again, common lupus syndrome symptoms. Here is the butterfly rash I was talking about. Now, when it comes to lupus and chronic fatigue syndrome, they're very kind of similar to each other and very difficult. Some things will be unique to lupus, like the butterfly rash, which is beneficial when the doctor is trying to diagnose what's wrong with the person. But quite often, all of this stuff is the person just doesn't feel right. And I'm sure we've all probably had friends or family who crushing fatigue and low-grade fever, and all the blood tests come back negative. And so they can't figure out what the heck is going on. Diagnostic findings, what I talked about. These slides are put together by Bill, so some of them, the slides are in here. I go, I'm not sure what he's talking about there. Nursing management. Some of these diseases can be totally debilitating. Some can be fatal. There again, what comes to mind, the crushing fatigue is chronic and can affect their lifestyle. But as far as debilitation, people with rheumatoid arthritis are going to have very difficult time using their hands. And so it's going to be up to you as the nurse to guide them and help them, for example, get occupational therapy, to use adaptive devices. I don't know if I have it on here. Now, let me see. Oh, yeah, okay. I think when I get to rheumatoid arthritis, I have some adaptive devices in here. I put a slide in here to show you. They'll have difficulty maintaining the role, especially if they are the breadwinner of the family. It can be interfered. Chronic pain. Encourage the patient to maintain activity. Anytime you're talking about osteoarthritis, rheumatoid arthritis, any kind of joint disorders, the best therapy for it is just to keep the joints moving. My father had osteoarthritis in his hands, so he took up gardening. It keeps the joints moving, it keeps the joints lubricated, and it just helps alleviate a lot of the symptoms of the disease. It doesn't make it go away, but it helps alleviate some of the symptoms of the disease. Support self-image by good grooming. That's kind of self-explanatory. Let's talk about chronic fatigue syndrome. Chronic fatigue syndrome, now this is definitely one of those where it's a process of elimination. The person has a set of flu-like symptoms. They're susceptible to upper respiratory infection, muscle pain, headaches. It's just it feels like you have the flu all the time. But really about the only way that we can determine it is through process of elimination. Nothing else comes back positive, so they must have CFS. They have figured out that you do have a deficiency of ATP. If you reach back into your microbiology days, you remember that is the primary means of energy. ATP is your gasoline for your body. So, of course, when that begins to drop, of course, you're going to experience severe fatigue. An important thing, too, is no cause has been established yet. We don't know where it comes from. We don't know what's causing it. There again, the key point here is exhaustive medical workup basically excludes everything else. Now, something I want to point out in nursing itself, when you're dealing with your patients, a lot of what we do in medicine is process of elimination. But a lot of the people out there in the non-medical world feel like we have tests for everything. It's like if you walk in and your liver's hurting, and we can run a blood test and tell you exactly what's going on. A large share of what we do is process of elimination. And that is why the doctor will say, I don't know what you got. And he'll run tests, and those tests will come back negative. And the doctor will continue to say, I don't know what you've got. So you go in for another test. And this is what frustrates patients. It says, you've run 5 tests on me. Why can't you tell me what I've got? They don't understand that a lot of what we do is process of elimination. Okay, your liver is swollen. Well, okay, it's not alcohol, it's not hepatitis, it's not this, it's not that. And hopefully at some point, we've either eliminated everything, so we really don't know what's causing the problem, or one of those tests will come back positive. But sometimes I try to tell my patients, just remember that this medicine is not an exact science, and we don't have a test for every single thing that could go wrong with the body. There are millions of disorders out there. So sometimes we just have to run a test and see if it's positive, and if it's not, we have to move on to the next test. It's process of elimination. So if they understand that, they're usually a little more patient about all these crazy tests that we keep running them through. But that's just a side note. There again, congestive heart failure. Chronic fatigue syndrome is definitely one of those process of elimination. When absolutely nothing comes up positive, you have CFS. I'm not even sure how definitive a diagnosis that is. As nurses, what our job is to help combat that fatigue and that chronic pain that comes along with chronic fatigue syndrome. Helping them to perform ADLs, the activities of daily living, during period. There again, adaptive devices, you know, it could be something as simple as a walker, a device to help them put their socks on, you know, anything. Try to encourage them to rest as much as possible. This isn't something they can power through. Their body needs time to rest and combat what's going on. Also dealing with chronic pain, we don't want the person to reach for the bottle of oxycodone every time they start having muscle joint pain. Try using warm packs or cold packs. That is kind of up to the patient. For some people, cold will work better. For some people, warm will work better. Whichever works better and alleviates the pain is what they should do. Nice warm baths help with joint pain. And try to get the pain down to the level where they don't have to reach for that Oxycontin every time they have an exacerbation of the symptoms. Any questions on what I've covered so far? I just kind of covered chronic fatigue syndrome or autoimmune disorders in a general sense so that you can kind of get a feel for it. And we'll go on to cover some of the more specific ones later. I think you cover lupus and rheumatoid arthritis in another class. In fact, I think we may be covering that in med-surg too. Anybody have any questions on anything?
Not yet.
I just basically put chronic fatigue syndrome in there as an example of what an autoimmune disease is. But like I said, you'll be getting lupus and rheumatoid arthritis in another class.
Okay.
Grace, I have an unrelated question.
Okay, I'm going to stop the recording then. If I can get my computer to work.